Thank you. Okay, here we go. This recording will be available on the UCF AAC Collaborative YouTube channel once it's complete, so you can go back to the recording and review anything that we covered during today's session. We would like to thank our funder, the WITH Foundation, which has supported the UCF ECHO Professional Development Training Series. And we would like to begin with a few reminders about the format of our ECHO sessions. We will start with a presentation of best practices related to this topic area presented by Dr. Hurtig, followed by question and answer session about the content presented. You are welcome to drop your questions in the chat. We will be monitoring the chat as the presentation moves forward, and we can present those at the end as well. Dr. Hurtig has offered a number of case study presentations for discussion, which will be discussed at the end of today's topic, and opened up for group discussion to share knowledge amongst the community as well as recommendations for practice. In terms of webinar tips, we'd like to suggest that you close any applications that may use bandwidth or other resources on your devices. As I mentioned previously, there will be a Q&A after the presentation. Please make use of the chat function for any questions or comments. And we ask that you do please remain muted during the presentation. Of course, you're welcome to unmute if you'd like to raise your hand and ask a question of Dr. Hurtig or any of us. Through the course of this series, we have been collecting feedback regarding the impact of the training on professional development in our community settings, both in terms of provider confidence and competence in providing AAC services to adults. The survey link for the pre-training survey is in the chat. Maria just put that there. If you have not yet completed a pre-training survey, we would appreciate you taking a moment to do so. Of course, participation in the survey is optional, but we do appreciate any data you're willing to share with us so that we can continue to refine the presentation and make it applicable to your needs and the needs of those in our community. So without further ado, I'd like to introduce Dr. Richard Hurtig, who is Professor Emeritus in the Department of Communication Sciences and Disorders at the University of Iowa. He's also an active contributing member to the Patient-Provider Communication Network and has great expertise in this area. So we welcome you, Dr. Hurtig, and thank you for speaking today on the topic of building a culture of communication in acute care settings. And I will stop my share so we can switch to your slides.
Oops. All right. Welcome, everyone. And as Julie just said, if you have questions, pop them up. And if it's something that needs immediate clarification, I'd be happy to do it. But obviously, hopefully we'll have time for questions and discussions at the end. Briefly, part of what we're trying to sort of accomplish today is to give you sort of an idea of what the barriers to effective patient-provider communication are in acute care settings, to understand the risks of some sort of negative outcome associated with barriers to effective communication. I'll describe a sort of a dynamic assessment process and how one can integrate that into success for patients who have barriers to communication and/or access. I'll talk a little bit about low and high-tech communication tools that can be used to support medical decision-making. I'll also describe how you can support the communication needs of patients that have limited English proficiency, because those are patients that, in a sense, face critical barriers that impact their care as well. And then I will want to talk a little bit about sort of how COVID-19 has impacted patient-provider communication in acute care settings. So imagine waking up in an intensive care unit. You're on a ventilator and you can't move. How you want to know, how did you get there and what's going on? How would you get someone's attention? And once you got their attention, how would you communicate with them? If you hadn't planned ahead and had not prepared an advanced medical directive, how would you let folks know what it is that you wanted them to do? If you did have an advanced medical directive on file, how would you let people know that you wanted them to follow it, or if you wanted to make changes? This can be a pretty stressful and depressing situation, but I hope the takeaway message from today's presentation is that it's a problem we can address. Historically, patient-provider communication has been seen as a one-directional exchange of information from the care provider to the patient. This more paternalistic mode of communication has hopefully evolved into a more bidirectional one in order to have patients more actively engaged in their care and thereby achieve better outcomes. Thus, the patients are becoming partners in care, and providers are shifting from just treating diseases to treating the particular patient with the disease. The Joint Commission's U.S. hospital accreditation standards mandate that hospitals address patients' communication needs and preferences. Of the few communication protocols that are in place, many leave patients who have limited use of their hands and cannot speak, still facing barriers to effective patient-provider communication. Over 11% of patients in U.S. hospitals are unable to communicate with their caregivers. For some, the inability to communicate is short-term, while for others, the loss will be permanent. In a study I did with Lauren Zubo in 2013, we found that 33% of the conscious ICU patients were unable to access the nurse call system or effectively communicate with their caregivers. Similarly, Mary Beth Happ and her colleagues reported in 2015 that 50% of their mechanically ventilated patients met their criteria for needing communication assistance. There are a lot of hospitalized patients with complex communication needs. As I said, for some, the inability to effectively communicate is due to some trauma or illness that results in the acute care hospitalization. For others, it may be some pre-existing conditions. The slides are jumping. I'm sorry about that. For some, the inability to communicate may be due to their pre-existing conditions, which render them unable to speak and unable to use the conventional nurse call system. Finally, there are patients who are unable to effectively communicate because they're not proficient in the language that's used by the hospital staff. Patients who face barriers to effective communication are 3 times more likely to experience a preventable hospital-acquired condition. Bartlett reported in 2018 that this was a serious sort of problem and that it needed to sort of be addressed. So I want to now turn to sort of looking at barriers to effective patient-provider communication from the standpoint of both the patient and the provider and the facility. Patients must be able to summon their caregivers, participate in their care, and be effective in how they communicate about their feelings and desires. The patient-centric barriers to effective patient-provider communication include the inability to use the nurse call system to summon help, the inability to express themselves orally, the inability to hear or see their caregivers, the inability to use writing to communicate, some sort of cognitive linguistic deficits that can impact either comprehension or expression, and the inability to communicate with their caregiver because of limited proficiency in the language of the caregivers. Finally, literacy barriers that are due to either visual impairment or poor reading skills can also complicate that communication. Now, if we take a look at the barriers from the provider and facility perspective, we see that, for example, the use of personal protective equipment, including masks and shields, make it difficult for the patient to understand what their caregivers are saying. That the other problem is that we don't really have staff or care standards that address the needs of these patients with complex communication needs. There are limited or no communication tools available to be deployed with the inpatient population. There's no systematic staff training on patient-provider communication that addresses the needs of these patients with complex communication needs. And finally, there's an inability to communicate with patients that have limited proficiency in the language that the hospital staff is using, and that therefore they have problems that arise also from the cultural differences that are associated with healthcare provision. What I want to do now is talk about the role that communication plays in bedside cares and infection control. When patients can effectively communicate with their nurses, it's much easier to care for them. We had a paper that we published in ASHA Perspectives in 2018, and I'll provide all of the references at the end of this presentation. We provided some illustrative cases of how communication barriers impact the critical components of care. That paper also provided detailed analysis of the impact of communication barriers on preventable medical events. When a patient can effectively communicate about pain, the caregiver can provide analgesics to relieve the pain, but perhaps more importantly, identify the cause of the pain. Early identification of pain can reduce the likelihood of a patient developing pressure sores and the risk of infections that can lead to sepsis and possibly death. When a ventilated patient is able to communicate about difficulty breathing, they're less likely to develop pneumonia. If a patient can't communicate that they need to be suctioned, they're at a heightened risk of developing a mucus plug that could result in death. When patients are given a new medication or a blood product, it's important for the nurse to monitor for adverse reactions. It's critical that the patient be able to effectively let their nurses know about new sensations or pain. When they can't, they're at risk for a range of adverse reactions that could lead, among other things, to anaphylaxis. When patients need something and can't summon help, they may try to move or reach for an object and fall and sustain injuries that require additional surgeries and extend their length of stay. When patients are unable to speak, they're often left out of medical decision-making, even when they're fully competent and should be involved. And when patients are isolated, communication barriers can contribute to increased stress and makes the patients much more prone to experiencing delirium and something that is now called post-ICU PTSD. The breakdown in patient-provider communication has negative impacts on both the patient and the caregivers. Poor communication increases the frustration and stress on both the patient and the caregivers. Patients who can't effectively communicate, as I said, are at a heightened risk of experiencing a hospital-acquired condition and delirium, which can result in an increased length of stay. When nurses can't understand their patients, there is a potential for errors in the care they provide, which can result in needing to provide extra cares. Allowing a patient to express anger and humor, while not directly tied to any particular bedside care, does effectively establish a critical rapport between the patient and the care provider. Poor patient-provider communication has been shown to influence patient and family members' perceptions of their care. Research has shown that nurses report that communication barriers result in wasted time and burnout. And finally, while many of the traditional communication tools currently used in hospitals focus on basic needs, they do little to allow the patient to be themselves and to allow the caregivers to see the patient as more than just a body that they're treating. I see that the slide moved without my touching the computer. I apologize again. I've mentioned hospital-acquired conditions a number of times. The incidence of these preventable hospital-acquired conditions has continued to be unacceptably high and adds significantly to the cost of healthcare. When patients are unable to effectively summon help and communicate about symptoms, they're at a higher risk of falling, developing pressure ulcers, experiencing adverse reactions to novel medications and blood products, and develop ventilator-associated pneumonias. As I said, Bartlett found that patients facing communication barriers are at a 3 times higher risk of developing these kinds of hospital-acquired conditions. Using the data from the U.S. Agency for Healthcare Research and Quality for the hospital population at large, one can calculate the expected hospital-acquired condition incidence rates for patients facing communication barriers. Even assuming the 20% reduction that the AHRQ expected in 2019, patients facing communication barriers are still expected to have a hospital-acquired rate of 79.9 per 1,000 discharges, and hospitals would face having to absorb an additional $9.6 billion in avoidable healthcare treatment costs. For many reasons, including the spike in COVID-19 related hospitalizations, we continue to see unacceptably high hospital-acquired condition rates, perhaps in part due to the communication barriers that patients continue to face. To specifically address the access and communication needs of patients in acute care, Voxello, this University of Iowa startup that I was associated with, developed the Noddle Smart Switch, which can detect the smallest intentional gestures, enable patients to summon help and to control the Noddle chat communication device that they were given. Voxello, with NIH support, ran some clinical trials that revealed that patients who received assistive technology did not experience any hospital-acquired conditions during the course of their hospitalizations. Comparisons of the clinically observed incidence with the AHRQ expected incidence for the population as a whole and for those facing communication barriers were statistically significant. I don't know what's causing the slides to advance with me not touching the computer. I apologize again. In one of our clinical trials, we assessed patient satisfaction with their care using a post-hospitalization exit survey. Patients were asked to provide Likert scale responses to the statements shown on the left side of your screen. The study compared the responses of 3 groups of patients: those who never experienced any access or communication barriers, those are the full access group; those who experienced barriers and received no intervention, that's the no access group; and then those who received assistive technology to address their communication barriers, and that's the group labeled Noddle. A one-way analysis of variance of the composite scores for the full access, no access, and Noddle groups revealed a significant main effect, and the Tukey follow-up comparisons showed significant differences between all 3 groups. So the no access group had the poorest sort of responses. The people who had no communication barriers had the best responses, and the people who got assistive technology sort of fell in between the two. The need to address communication barriers is not just something that speech-language pathologists have identified. The Joint Commission, which accredits hospitals in the US, has mandated that hospitals address the communication needs and preferences of patients from admission through discharge. Furthermore, the National Joint Commission has declared that individuals with impaired communication have a right to functional assistive technology. If we look at legislation, the Americans with Disabilities Act, Title III, specifies that hospitals, along with other places of public accommodation, must address the communication needs of individuals with disabilities. The U.S. Department of Justice has identified that as something that is critical and that it's important that we address the needs of those with communication impairments. Sadly, there are many hospitals and nursing homes around the country where little or nothing is being done to address the communication needs of their patients. So we know that when patients encounter barriers to communication, they tend to have poor outcomes and are at higher risk of experiencing preventable adverse medical events. And as I said, the data suggests that patients who face communication barriers have a 3 times higher risk of experiencing these preventable adverse events. These patients feel isolated and are unable to participate in critical medical decision-making. Regardless of the reason, when someone is unable to speak, they're more likely to be treated in a paternalistic way and subjected to the disrespectful, elder speak or baby talk. In order to address the range of barriers to effective patient-provider communication, it's essential that the bedside caregivers engage in dynamic assessment of each patient's ability to summon help and to effectively communicate. Working with the Department of Nursing at the University of Iowa Hospitals and Clinics, we developed a way of building such a dynamic assessment into the clinical flow sheet and trigger consults for patients who cannot use the nurse call system and or are unable to use speech or writing to communicate with their nurses. This dynamic assessment protocol also addresses the communication needs of patients with limited English proficiencies. One of the reasons it was important to integrate the state of the patient-provider communication into the flow sheet was the realization that there was a problem with getting adequate handoff from one nursing shift to another, or when patients were transferred from one unit to another, or if they were being transferred to another facility. This protocol was in part designed to address the specific Joint Commission standards that mandated ongoing assessment of communication barriers. The success of implementing any program to address communication barriers will require a workflow that should include communication champions among the professionals who have direct patient contact. Depending on how each institution is structured, the champions could be speech-language pathologists, nurses, physicians, physical therapists, occupational therapists, and even respiratory therapists. No matter how skilled the champions may be at providing tools to overcome communication barriers, the successful implementation of communication tools and strategies will require a hospital-wide engagement in ongoing education, training, and support of all hospital staff who will be working with the patients. Ideally, every facility should have a range of communication tools that would enable non-speaking individuals to actively participate in their bedside care and indicate their needs and preferences, and not be limited to making only binary yes/no responses. Here's an example of a tool that I have developed.
I use this app to communicate. Please be patient while I select what I want to say. Make sure to verify that you have understood what I am trying to say.
Now, in this grid, you see you can go to feelings.
I am okay. I feel hot.
You can talk about pain.
I am in pain. My hand hurts.
You can crack a joke.
What does a lazy dog chase? Parked cars.
Dr. Hurtig, may I ask, should we be seeing the different images for or the written words for those messages on your screen?
No.
Okay.
You're just hearing them.
Okay, thank you.
Good question. In principle, you could make the tool do that, but this one does not. You can give people a keyboard, but obviously in this tool, because it's not a real SGD.
Please write down what I am spelling and verify that you have understood what I am trying to say. H E L L O.
So now what I want to do is show you a tool that allows patients to actively participate in their care and to participate in medical decision-making. To that end, hospitals have to have a range of communication templates that will allow non-speaking patients to participate in that medical decision-making. And it should be the case that these templates make it easy for patients to demonstrate that they've understood the consequences of the decisions that they're making, and that it makes it possible for patients' wishes to be as unambiguous as possible and clearly grounded in the current situation. So I'll just give you a little peek at this. So, for example, a patient, what is my problem? I will be taking medicine. I would like further clarification. Use a different strategy to explain. Am I going to live? Am I going to die? Now, these are very painful things to sort of see, but really it's if somebody's thinking these things and they don't have a tool that allows them to bring that out, that's sort of a real problem. And, you know, part of it is also who do they want to talk to about that? So, for example, I want my family to know. I don't want my family to know. Or, for example, they can, when you get to ventilation, why am I on a ventilator? What happens if I'm taken off the ventilator? Don't take me off the ventilator. I do not want to talk about this now. When do I have to decide what should be done? And often, can I have a ventilator at home? I don't understand. So in this tool, we have a wide range of things that they can talk about. And again, they can sort of move very quickly through that. Now, as I said, we have to support patients with limited proficiency in the provider's language. Ideally, there should be a live or a remote interpreter available 24/7. But realistically, it's not possible to have interpreters at the bedside 24/7. And even if they have the ability to dial into an interpreter, if a nurse has to quickly do something, or if a patient is experiencing something, they're not going to want to wait for an interpreter or somebody to think that an interpreter should be brought to them. And so it's important that we have these tools. Here, this is an example of a bilingual communication tool that was developed by the Patient Provider Communication Network when we were pulling stuff together for the COVID-19 crisis. So I'm going to just give you a couple of examples here. So you can basically create low-tech bilingual sort of tools in which the message is available in the staff's language and in the patient's language. And so apropos what I showed you with medical decision-making, here, again, they could point to the message that they want, and they would be able to read it in their own language, and the nurse would then be able to sort of see what that was. Here's a version of a bidirectional communication tool. So if the nurse very quickly, for example, has to give the patient an injection, okay, it's an emergent need. They can't wait to connect to an interpreter. It has to sort of be done. The nurse can go. So the message is written in English, so the nurse understands it. And in this case, it produced an officially translated version of that message in Spanish. The patient has the messages labeled in their language, and then it produces the officially translated version in this case.
I am in pain.
Okay. We always.
I would like an interpreter, please.
So that the tool makes it possible for the patient to always have the ability to get, and then the nurse can always respond, which, if you didn't understand Spanish, was I will get you an interpreter. All right, so we were working on all of this stuff, hoping to sort of improve patient-provider communication, build cultures of cultures of communication in hospitals, and COVID came, and we were hearing from a lot of our partners around the country that their hospitals' infection protocols were limiting who could be at the bedside and what kind of equipment could be brought into the room. And so we in early of March 2020, as the pandemic spread, I brought together a group from the Patient Provider Communication Network to see if we could very quickly develop a set of tools that could be downloaded for free from the Patient Provider Communication Network, along with strategies for how they could be used in hospitals treating COVID-19 patients. The members of the task force included clinicians from Boston Children's Hospital, Massachusetts General Hospital, NYU Langone Hospital, Ohio State University College of Nursing, Wisconsin Health and the Waisman Center, the University of Nebraska Medical Center, and my Voxello University of Iowa healthcare team. The task force used their collective years of experience addressing the communication needs of pediatric and adult patients to develop a set of communication tools that could be quickly and easily deployed in the COVID ICUs. By later in the third week of March, those tools were made available on the website, and announcements were posted on social media and to various speech language pathology and nursing listservs. As of June of 2022, 105,233 unique users from 191 countries accessed the Patient Provider Communication Network for a total of 316,236 page views. We were sort of very pleasantly surprised that our efforts had been used that much. I was interested in the relationship between the COVID-19 case rates and the utilization of the Patient Provider Communication Network's website's COVID-19 communication tools. This slide plots the Patient Provider Communication Network's users against the WHO reported COVID-19 case rates. I performed a regression analysis of the data for 185 countries for whom we had both website usage data and WHO reported case rates. I also performed the regression analysis for the 43 countries with 100 or more website users. Both analyses revealed significant positive relationships that accounted for in one case, 60, another 57% of the total variance in the data. Some of you might say, you know, why is it that the total number of website users is lower than the WHO reported case rates? And that's because basically WHO doesn't report cases for Taiwan, Hong Kong, and Macau. And so that's what accounts for that difference. Now, I was interested also specifically in the utilization in the United States And the figure on the left shows the bi-state relationship between the patient-provider communication network users from the USA and CDC COVID-19 case reports. The regression analysis revealed a strong positive relationship that accounts for 85% of the variance. As the bulk of the patient-provider communication network participants are speech-language pathologists, I was interested in whether there was a relationship between the patient-provider communication network website usage and the number of speech-language pathologists employed in each state. The figure on the right shows a plot of the patient-provider communication network's users by state employment data obtained from the U.S. Bureau of Labor Statistics. The regression analysis showed a strong positive relationship that accounts for 89% of the variance in the data. What we don't know is how many of the speech-language pathologists employed in each state work in healthcare settings and how they use the patient-provider communication tools. In addition to some free communication tools that can be found on AAC vendors' websites, you can find a range of generic communication tools at my personal website, as well as those of the patient-provider communication network and of Widget Health in the UK. It's worth noting that the bilingual tools originally developed to address the needs of patients with COVID-19 were used to address the needs of pediatric and adult patients who had to be evacuated to other countries because of Russia's invasion of the Ukraine. Okay, I'm happy to entertain any sort of questions, and then we can turn to some cases as well.
Thank you, Dr. Hurtig, for that really comprehensive review and the data to support some of the questions you folks have been asking. I'll open it up to the audience. Please feel free to unmute yourselves if you have questions. We didn't have any come in through the chat during the presentation, but I'm sure there are some out there in our audience. So we're happy to pause here and take questions. If there aren't any from the audience, if I may ask one question related to the impact of providing these communication supports to folks in their acute care setting. Have you personally interacted with patients who had access to these supports and then were able to reflect back on their experiences once they were out of that acute care setting and in a more stable place of recovery?
Well, there are two answers to that. I mean, we have individual sort of reports at the from individuals who were provided a communication tool, whether it was because they needed it, because they were intubated, or because they didn't speak English, or in some cases, sort of both. They are both patients and their family members felt that prior to having a communication tool, they were sort of very distressed. If you look, for example, at sort of kids in pediatric ICUs, the parents are really, really wary of leaving the bedside because they're so concerned that if they're not there to sort of watch over their child and advocate for their child, something sort of bad can happen. When we are able to introduce tools that give, in a sense, the child the ability to A, attract somebody's attention, and B, let them know what it is that they need, it has sort of a beneficial impact on both the parent and the child. The parents are feeling a little bit more comfortable running off to the bathroom or, going back to get a shower. And for the kids, interestingly, especially for the adolescents, they want to be left alone. And so the tool basically gives them the ability to control the situation. We had a number of cases of people who were admitted to our ICUs at Iowa who were trying to, in a sense, sort of manage their lives and their affairs. And we had one elderly farmer who was simply trying to sort of deal with the whole issue of insurance and healthcare. And it was a really sort of a challenging situation. And eventually what gave him, made it easier for him, was that the speech language pathologists included instructions to his family to sell a cow or two to cover expenses. And so one of the things that we learned, both from the kids and the adults, is that the kind of messages that need to be in these communication tools are not just, I'm in pain, turn me, I'm thirsty, I'm hungry, but rather things that allow them to sort of maintain their identity. And as I gave you in the example earlier, where we embedded Huber, it was the kids who really wanted people to think of them as kids and not just as this pincushion that people were sticking things into. I worked with a young guy with Duchenne's muscular dystrophy, and we had basically come up with a way to sort of adjust what was in his communication device from day to day. And on my way home, I always stopped by, and he always wanted me to program a new sort of funny thing or joke that he could sort of play on everyone the next day. The example I'm going to give you is, please understand this was a 13-year-old boy, not a 78-year-old man. His mother had given him, all sorts of things, stuffed animals and other kinds of stuff. And one day she gave him this long stuffed animal snake. And what this young boy asked me to program was pull down my covers and see my snake. And he basically, I walked into the unit the next day and the nurses said, oh, this was so great. And I said, it's a good thing he wasn't 78 years old. But basically, that breaking of the ice, in a sense, changed not only his own feelings, but also the way in which the staff sort of dealt with him. I had another pediatric patient who was going to have a repair of cervical spine sort of issues. For this group of patients, we actually saw them pre-op, and so we introduced them to the device that they'd have to use during the post-op intubated period. And I would always let the kids sort of get accustomed to it and, add any kind of special messages that they would want. And this particular class of messages also had an on-screen keyboard so they could type, whatever they wanted. And unfortunately, this girl had to be sort of intubated pre-op because of another heart condition. And I was coming in to check on her, and head of pediatrics was coming out of the unit. And he said to me, Richard, providing these communication tools are really phenomenal for the kids, but you've got to put a 4-letter word filter on these. I mean, she is just sort of cursing up a storm. And I said to him, if you didn't intubate her and she was upset, that's probably what she would be telling you. And so while it's not necessarily the case that everything on the board, is very nice and clean and polite, just like some people might find it objectionable to have something on the board that says, "Am I going to die?" I think that we have to sort of understand that we have to provide these people who are unable to create messages on their own to have a series of messages that allow them to actually get at the content that they want. Long-winded answer. I'm sorry.
No, that was wonderful. Thank you. And you touched on so many themes that you raised during the presentation, especially related to preservation of identity for folks who are non-speaking for a period of time in the acute care setting, which is such a critical piece. And it relates directly to patient-provider relationships, which impacts care. So thank you for that. Any other questions from the audience?
I don't have a question so much as a comment. I do not work in an acute care setting, so I was just joining and hopes to learn something new and kind of be up to date in this area. But I found it early in the presentation, you mentioned the impact of communication related to adverse events in the hospital, things like falls and med errors and things like that. And I think it was just really good for me to consider how much of that is due to inability to communicate effectively among patients. I think I'm definitely aware of those things in the setting that I'm in. We do get trained on them, even though I'm not in the acute care setting. And I think I typically always just view those types of errors through the lens of there being a communication breakdown between providers, rather than them thinking about the impact of the patient themselves being able to communicate effectively. And so that was just a neat thing for me to consider and think about, and I appreciated it being mentioned.
You raise a really good a good point there, that we have a tendency to sort of always sort of view things in terms of the provider side of things, and that really part of what we all have to sort of become aware is to think about those interactions from the patient's sort of perspective. And one of my sort of the causes that I want to push, especially for patients that have sort of who are in a sense sort of dealing with chronic barriers to communication. So kids with developmental disabilities that use some form of AAC, or even adults, who ALS patients who require some sort of AAC to communicate. That really the clinicians that are working with them in home, in school, or wherever, really have to sort of think about what happens when this individual lands up in a medical encounter. Have I built the communication tool for them so that they can effectively sort of participate that way? We know from sort of disaster relief situations that if the devices and the tools that people have don't come with them, how are they going to communicate in that situation? Or if the tool was developed solely to deal with the educational needs of the child and the sort of social communication, but doesn't even give the child the ability to tell somebody where their pain is. And so I think that while I want to build a culture of communication in acute care settings, I think the profession as a whole has to sort of view building communication tools for people with complex communication needs so that they can function effectively across settings, and including the acute care setting should they have to be hospitalized.
Right, that makes a lot of sense. I even thought about it incredibly simply, like thinking about a fall. If a patient could say, I'm dizzy, or my legs hurt, or I need to take a break, or I need to sit down. I mean, even something as simple as that perhaps could bring those numbers down, or being able to ask, what medication is that? Or, hey, someone gave me a med 5 minutes ago, or whatever it might be. Just really, really simple communication on the patient's part that could, possibly prevent dangerous situations.
Absolutely.
Dr. Hurtig, if I may ask one more question before we jump into the case studies. The title of your talk is obviously building a culture of communication in acute care settings, and you mentioned some of the barriers that present challenges to doing so. I wonder if you could share with us just your perspective on the role of the SLP in supporting the nursing staff or the physicians, the caregivers, the cleaning folks, everybody who comes in contact with the patient in an ICU or acute care setting, so that culture of communication becomes more the norm and not the exception.
An excellent question. I think that the SLP is the person who, in a sense, has the training and the background to understand human communication, and hopefully will have gotten in their training, the basis for developing tools that patients facing complex communication needs can address. So there aren't one speech pathologist per patient with a complex communication needs. So that the speech language pathologist really has a consultative sort of role, both with regard to the patient, but more importantly, it's not just go in there, build a device for the patient, train the patient how to use it, but you have to basically train the people who are going to be at the bedside. And so one of the things that we've worked on a great deal is developing training for nurses. Many of the hospitals I work in, it's the speech language pathologists that develop those training modules and provide both sort of pre-service training modules, but then even participate in those nursing huddles with just-in-time kinds of training. Mary Beth Happ, who's an associate dean of nursing at Ohio State, has developed the SPEAKS program, which is a fairly intensive nurse training program on patient-provider communication. But one of the things that we've learned is that you can have all of this training material, but if you don't have a way of supporting it in the day-to-day situation, you have a problem. So, we instituted a fairly good sort of new nurse training module that the nursing program at University of Iowa Hospitals gives. But if there's a big temporal disconnect between when that information is provided and that a particular nurse encounters a patient that has a communication barrier, you have a problem. One of the things that I did when we were starting to put the Voxello technology into the hospital, we developed a series of tiny, short, little how-to videos for a wide range of not just to use the technology, but how to use strategies. And the nursing department put all of those short little videos on their intranet. And so the nurses with their smartphones could very quickly pull something up, either to refresh their own sort of skills, but if they wanted to demonstrate what something might look like to their patient, they could just put it up on their phone and quickly hold that up so that the patient could see. That has some sort of success. I think that when COVID came, and at first because of the limited amount of PPE available, staff like SLPs were in a sense sort of barred from coming to the bedside. But as sort of the protocol sort of evolved, they were able to come onto the units. And so what they were able to do was to train the staff, using, a video link. So they could be literally outside the glass wall, but using their smartphones and stuff, guide the staff at the bedside on how to do that. I think that once the speech language pathologist develops a really good working relationship on a particular unit, so that everyone knows, oh, if you have a patient who has sort of a problem, the SLP is the person to go to. I think that, one of the perfect examples of that is at NYU Langone, where Tammy Altschuler has sort of worked in the intensive care and has basically involved training everyone, the nurses, the physicians, the other therapists, and as somebody mentioned, even, the people who are the cleaners and the dietary folks, that you land up with a very different kind of an environment. And that it's not something that you give somebody a pill and communication problems are solved. This takes time. Building that culture takes time. That flow sheet that I showed earlier, it takes time to convince the electronic medical records folks to build that kind of system sort of in. But if you get that done, either electronically or just simply in people's heads, to think, is my patient conscious? Can my patient summon me? Yes, good. If not, who do I call? Well, in the flow sheet, it automatically triggers the consult to get somebody to bring an accessible nurse call system in. If the answer is my patient is conscious but can't communicate, is that because of a language difference? If it is, that triggers the interpreter services. If it's not a language issue, it triggers the SLP consult. And then the key thing is that all of these consultative services have to be responsive. Critical care is something that can't wait, for somebody to come 24 hours later, 48 hours later. And so you build this culture of communication by being responsive. Now, the SLPs are stressed. Okay. In lots of hospitals, the workload is high, the productivity measures are high. And if the speech language pathologist is not just the communication person, but also has to deal with dysphagia, you get a really challenging situation. And to be sort of very frank, COVID-19 has created a tremendous amount of burnout. We've had, nurses, nurse managers sort of choose to sort of retire. We've had SLPs that, worked tirelessly through the entire COVID thing, who basically sort of, and that's a real challenge, because when you have some of these champions leave, there can be a vacuum.
Yeah, thank you for that. And I really appreciate the comment that it takes time to build this up in continuity and responsiveness. If there are no additional questions from the audience at this point, I think it's a great time to shift to some of the case studies that you've prepared to share with us.
Okay. Okay. Oh, for some reason. Okay, so Mrs. Jackson was a 67-year-old woman admitted for cardiac surgery. She's on ventilatory support and is on an intermittent sedation protocol. What that means is that for various periods of the day, she is fully sedated, and then the sedation is backed off, not just for a few minutes for staff to sort of do sort of cares, but for longer and longer periods. And the rationale for the shift from keeping patients sort of fully sedated until they're extubated is that we have discovered that the likelihood of delirium and the incidence of post-ICU PTSD is greater in patients that are on full sedation, and that this intermittent sedation and early mobilization really reduces sort of those risks. Now, just remember that if you have a sedated patient, the patient is not, in a sense, sort of subject to a communication barrier. But if you back off the sedation and now you have a conscious patient and you have a patient who can't communicate, that raises stress. And so that's sort of a challenge. So that the only way you can really do these sort of intermittent sedation protocols and early mobilization are if you think about how you're going to allow the patient to communicate, especially these ventilated patients, when you have backed off on the sedation. So this patient initially, was simply when they backed it off, said, I'm gonna, whenever you need something, thumbs up for yes, thumbs down for no. And what happened was that the nurse came in and the nurse said, would you like, are you feeling a little tired? We can, we can put on the sedation. And in this case, in this one situation, Mrs. Jackson, was aware that her family was on their way. And so she really wanted to have some time with them. And so she didn't want the sedation to be started right away, because then she would sort of miss out on that. But she was worried that if she said no, and therefore would be up, that she wouldn't have the opportunity to get the sedation later. And this was one of those cases that led, the staff to really realize that when I was saying yes and no is not enough, that you really have to give them yes, no, maybe, and later. That basically solves this sort of problem. Because basically, if she had been able to say later, right, then they wouldn't have put the sedation on. She would have had her visits, and she would have known that she had told and was confident that she would still have the opportunity to do that. So how do you do yes, no, maybe, and later if you have a patient who can not only do this? So you can create a very simple little tool that has yes, no, maybe, and later, and you use basically a partner-aided sort of communication strategy. So do you want your meds? Is it this? Is it this? Is it this? Is it this? So is it, you mean yes? Do you mean no? Do you mean maybe? Do you mean later? Okay, and so it's very easy to do. It doesn't take all that much time. It's very easy to train up nurses to understand how to do this partner-aided, especially on a simple yes, no, maybe, later communication tool. Anybody have any questions or comments about this case? I've got another case if you want. All right. Mr. Jones was 84 years old. He was admitted to the ICU after a really tragic fall. He had been a very active, vibrant individual, totally independent. And he suffered a significant C3 spinal cord injury and multiple other fractures. He was effectively locked in and ventilatory dependent. And they had him on sort of intermittent sedation. And he did not have any sort of advanced medical directive, living will, or healthcare proxy. And his prognosis was really poor, that, basically quadriplegia requiring ventilatory support and artificial feeding. And he was at the bed, and his two daughters were sort of brought in. They were sort of told what the situation was. And I refer to this case as the dueling siblings case. The one daughter said that was talking out loud in the room. Maybe they were unaware that their father was not sedated, and she was saying, "Dad was a fighter. He would never want to give up. We've got to keep him on the vent, and anything that will keep him alive, he would want." The other daughter said, No. Dad was a fighter. He was active, and he would never want to be, in a sense, dependent and so unable to do anything on his own. He would not want to be maintained on the vent. And one of the nurses I was working with noticed that Mr. Jones had been monitoring all of this, and she saw tears running down his face. And so she immediately sort of got the two women out of the room, did a consult for the SLP. The SLP came, they did an evaluation of his sort of ability to understand the situation, and using, some of the hospital sort of competence ethics sort of protocol. He was able to demonstrate that he was, aware of his situation, aware of the consequences of, mechanical ventilation, what would happen if he was to stop having that. So the SLP developed some communication tools for him that were used with partner-aided scanning. The SLP participated in that initially. The nurses sort of were also sort of brought into this. And Mr. Jones was able to tell his daughters that he did not wish to be sort of maintained or kept alive on the ventilator, and that he wanted to have this withdrawn. But he also indicated that he wanted to have a day or so that he could communicate with each of his daughters about life and other things. And what that did was, it gave him autonomy, it made him the decision maker, and it saved those two women from a lifetime of animosity, because had one or the other one out, the other one would have always sort of been. And so providing that communication tool allowed the patient to participate in medical decision-making, to have autonomy. It allowed the family to, in a sense, sort of not be put into a conflict situation. It was a simple set of communications. It was a simple realization that even though you have a patient who can't move and is on a ventilator, that basically there's a likelihood that there's a competent individual locked into that body, and that a very simple set of communication tools can allow that individual to effectively communicate. Anybody? Comments, questions?
I wonder if there was any pushback from the family, or if they, if it was, once this support was provided, they transitioned to like accepting his wishes.
In this case, because I was able to sort of be there, I think that he was such a dominant force in that family that when it became clear to both the daughter, who wanted to hang on to her dad forever and not lose him, and for the other, that basically they both understood that he was the boss of the family, and so they were first of all, neither daughter was resistant to the father being able to communicate, and so neither wanted to sort of, in a sense, control his life. There are situations where the family dynamic is such that they're not. I mean, I had another patient who was dying and in severe pain. This was a cancer case, and she had a friend who basically sat with her, and the friend basically, sort of prayed, with her or for her all the time. And this friend really pushed back on the patient's ability to communicate to the nurses that she's in pain and should have medication. And the hospital basically at one point had this woman sort of removed because the woman was telling the patient, no, you don't want them to give you pain. God wants you to, this is God's will, and pain is what God wants for you. And in this case, the hospital sort of intervened and allowed her to be able to ask for pain medication. It's all, we can't ignore that, people's taste, people's ethical and moral, things sort of differ. Sometimes there are cultural differences. So, for example, there are some cultures in which letting the patient who is dying know that they're dying is the norm. But there are other cultures in which the family members are told, and it's the family members or the elders' decision about what is and isn't told to the patient. And we have this sort of conflict because, in a sense, in our society and in our regulations, okay, a competent patient is the decision maker. And only if that person delegates the decision making in a legal document to someone else does the other person make those decisions. But when we, are brought into the situation, we're trying to sort of build a communication with the providers as well as with the family members, we have to sort of be sensitive to those cultural differences and figure out a way to sort of find that path that gives the patient, sort of the best outcome.
Thank
I have
you.
a happy ending case. So Mr. Williams, younger man, has a poor prognosis in that he has a neurodegenerative disease, and he was admitted to the ICU because he was having sort of respiratory difficulty, and he was orally intubated and put on a vent. And it was clear that as they were trying to do, sort of weaning him off the ventilator, that they were not sort of succeeding. He, because they had thought that he was not going to be intubated all that long, they had simply developed a low-tech communication tool. At this point, he was still able to sort of speak. They just simply developed a yes/no question sort of response. And they were saying to him that because he was not able to, in a sense, sort of breathe on his own, that they would have to sort of perform a tracheostomy. They were basically going through an oral consent protocol, and we had to respond, yes, I wanted. And he kept on saying no. So people were starting to say, well, is he basically saying, well, if I can't breathe on my own, I don't want to be kept on a vent? So saying no to the tracheostomy was basically an end of life decision that he was indicating. And again, this was one of those situations where the speech pathologist had, sort of just this little, why is he saying no? I mean, he has basically had this history, throughout the course of his illness of, in a sense, undertaking things. And so said, we need to have more than a yes/no here. And so in the end, it turned out that the reason he was saying no was that he had been intubated when he was fully conscious, and it was a not pleasant situation. And he had the misconception that the tracheostomy was done without sedation. And that's what he didn't want. But when it was made clear, because of his responses, that no, this is not, we're not going to cut into you, and you'll feel pain. He said, oh, no, absolutely, I want it. And so this is a situation where, again, the yes/no can be by itself a very dangerous sort of communication tool. And that really, whatever tool you use, whether it's yes/no, having a verification that you understand the response and why the response is being made. So providing that sort of feedback. So if somebody says, you're saying no, does that mean that you don't want to be kept on a ventilator? Right? If the patient says, oh, I want to stay on the vent, okay, then you already begin to sort of understand that. So the reason I say that this is of the three that have, at least at this stage, upon being able to be released from the hospital, okay, he had a sort of a positive sort of outcome as a function long-term of that, because had they simply taken that first no to mean I don't want to stay on the vent, his wishes to stay alive would not have been met.
Thank you so much, Dr. Hurtig. Before we transition to the post-session wrap-up, do we have any questions or any final comments for our presenter today?
I have all of the various studies that my group has sort of done that sort of informed today's talk in this presentation. And, you know, I always welcome follow-ups, you know, so if you want to reach me by email, I'd be happy to answer any questions. And then there's a lot of stuff that's related to today's talk, plus a lot of my papers and other presentations at my website. So you can sort of access that as well. So I'm all yours now.
Wonderful. Thank you so much. We did put some of those links in the chat as Dr. Hurtig was speaking. So please be sure to go back and check the chat box for active links that you can click on. I will share my screen now to bring us to a close.
I have to stop my. Yeah.
Yep. Thank you so much. So our final, let's see, is everyone able to see? Yes. Okay. We do have a post-session survey that we would like to encourage everybody to complete. Even if you have done a post-session survey in the past, we are asking for you to complete one for each session so that we can identify things that worked really well and things that we should think about for future trainings. Maria is dropping the link for that in the chat box right now, so you can access it quickly. Again, this is optional participation, but we do appreciate any feedback that you're willing and able to share with us. A few reminders for upcoming sessions. On November 30th at noon, we will have another ECHO session that focuses on brain-computer interface as an AAC access method. If you have a case study that you would like to submit for discussion for this particular topic, you can submit it using the Qualtrics link on the slide. I believe Maria will add that to the chat as well. You can find this and future ECHO session offerings on our UCF ECHO website. The link is at the bottom of your slide to access that, which also includes links for registering for our final upcoming sessions. And then as a final few reminders, you will receive a participant form in your follow-up newsletter via email after the session. If you have been with us for the series or have joined us for more than one session, you do not need to complete out multiple forms. Please fill out one form and submit it at the end. And as a reminder, you will only receive CEU hours for live sessions that you attend. Unfortunately, we cannot offer those for viewing the recorded sessions at this time. And finally, we would like to say thank you, Dr. Hurtig, for sharing your knowledge and expertise and practical application of these ideas during today's session. We'd also like to thank the UCF AAC collaborative group, Dr. Kent Walsh, who was on the call today, as well as Carolyn Buchanan and our graduate research assistant, Maria Veras. You can find the recorded sessions on the UCF AAC YouTube channel, which will go up shortly after today's talk. And we look forward to welcoming you back to future ECHO sessions. Thank you all and have a wonderful rest of your week. And just so you know, Dr. Hurtig, there were many thank yous coming in through the chat. People were writing that they enjoyed the session and that it was really informative. So thank you again so much for your participation.